Good afternoon to all of you on the East Coast, and good morning to you if you are on the West Coast. My name is Dr. Jose Leon. I am the Clinical Quality Manager at the National Center for Health and Public Housing, a project of North American Management. I want to welcome and thank you for attending today's webinar, Patient-Centered Medical Home Accreditation and Recognition Process. This webinar is being recorded, and the resources, slides, and other materials will be emailed to you after the webinar has finished. I'd like to get started and introduce our speaker for today's webinar, Cindy. Miss Cindy Cook is currently the Senior Director of Business Development for URAC. She joined URAC 7 years ago and brings to the organization over 20 years of experience in the healthcare industry. Ms. Cook is a registered nurse who, in addition to clinical practice in acute care, home infusion, and medical management, has spent the last 10 years in marketing and sales, working with both domestic and international healthcare companies. She continues to stay current with trends in healthcare by volunteering at a not-for-profit healthcare center serving the uninsured. I would like to share some data with all of you. Only 20% of United States adults can easily contact their primary care physicians by telephone, obtain care or advice after hours, and schedule timely office visits. The 2013 National Health Interview Survey estimates only 86.2% of persons have usual place to go for medical care. 25 states have implemented patient-centered medical home initiatives and have seen improved health outcomes, improved healthcare delivery, and or lower overall healthcare costs. Without further ado, I would like to introduce Ms. Cook. Good afternoon, Ms. Cook.
Well, good afternoon, everyone. Thank you, Dr. Leon, for your kind introduction. And thank you to everyone who is joining us today for this webinar. I know that everybody has very, very busy schedules, so I do appreciate your taking the time out of your schedules to join us today and have the opportunity to learn a little bit about URAC and URAC's patient-centered medical home. Before we begin, I just want to make sure that everybody can indeed see my slides. If you can't, please shout out and we can take care of that technologic hitch if we have one. Great, not hearing anybody that's not able to see the slides. We'll go ahead and get started. As Dr. Leon so kindly introduced me, my name is Cindy Cook. I am the Senior Director of Business Development here at URAC, and I would like to make this very much interactive, so if anyone has any questions along the way, please feel free to either interrupt me, or you can actually ask the questions through the web link, and we can certainly respond to them at the end of the presentation. And or if someone has a question that pops up after the presentation, I will provide my contact information at the end of the presentation. Please feel free to contact me at your leisure. The goals of today's webinar are really to understand who URAC is and to describe the overall approach that URAC uses to accreditation. I'm going to provide you with a very brief overview of our provider suite of accreditation programs, and we'll take a little bit of a deeper dive into the scope of the Patient-Centered Medical Home Practice Achievement Program and to understand how that process works. So first on our agenda is who is URAC. We are a nonprofit organization that is based in Washington, D.C. The acronym URAC was actually born from our original name, which was Utilization Review Accreditation Commission. That name was actually chartered as a result of our very first accreditation product, which was utilization management. And that first program was launched in 1990 as a result of what was happening in the industry at the time for those of us who've been in healthcare for quite some time, you'll remember that that was really the advent of managed care. And there was concern about the ability for consumers to have access to good quality medical care, and therefore a group of individuals got together and formed URAC and actually created those very first standards for utilization review. Over the years, since 1990, we have grown and have now in our portfolio more than 30 distinct accreditation programs that really cover the entire continuum of healthcare services. We currently accredit 175 different distinct programs operating in all 50 states, and I'm delighted to also share with you that we also provide accreditation internationally, having as recently as 2 years ago had recognition from Abu Dhabi for our pharmacy benefit management accreditation program. So we're very proud of the work that we've done in healthcare and continue to do in healthcare and respond to what's happening in the marketplace. We have government recognitions across the country. We have states that recognize our programs in lieu of some licensing and some oversight issues that a state may have. You'll see reference to URAC in requests for proposals and contract language. And we also do work with federal agencies such as the Office for Personnel Management, the Department of Defense. The Veterans Administration, for example, uses URAC's accreditation program for Health Call Center as a requirement for their Veterans Administration triage centers and their call centers. So we have a wide, diverse experience in the healthcare industry, and are delighted to have the opportunity to speak to this audience and give you some understanding of who we are and what we do and how we can assist you in your endeavors going forward. Our mission, as I mentioned in the last slide, is really about continuous improvement in quality and the efficiency of healthcare. We do this through three processes. One is the accreditation process, the second is education, and the third is measurement. I'd like to take just a moment to talk about the education piece because that is really critical to who we are. Our accreditation process, our recognition process, our work is really intended to be educational. We are not punitive. We are not an organization that will come into your organization and for lack of better word, ding you on process. We are really about helping you to showcase the good quality care that you're providing to your consumers. And in those areas where there may be a deficiency, where you may need some assistance in identifying how to put together those policies and procedures that are necessary for delivering good quality care, we can provide you through our accreditation reviewers an opportunity to connect with subject matter experts that can help you with that endeavor. And lastly, in terms of measurement, we'll touch on this ever so briefly as it relates to patient-centered medical home. Well, we are embarking on state-of-the-art measurement tools to assist our customers, our applicants, our accredited organizations in really measuring the work that they're doing and providing outcomes, which we all know are so critical in today's environment. As I mentioned, our structure is one of being nonprofit. We are based in Washington, D.C., and by design have a broad-based governance. Our governance includes representation from providers, individual providers, as well as provider groups. We also include on our board purchasers, regulators, patients, subject matter experts. So we have a very diverse broad-based governance so that we can be sure that we are including representation from across the stakeholders in the industry. Our strategic focus, as I mentioned, is one of patient protection and empowerment and innovating healthcare management. This slide represents the board member organizations, as I had previously noted. You'll see that organizations such as the American Academy of Managed Care participates on our board. The Case Management Society of America participates on our board. The Preferred Provider Organization for Physicians participates. So you can see that we are incorporating providers as well as subject matter experts in their particular clinical field. But the reason why we're together today is to talk about the provider suite of services, and specifically I'll be focusing on the patient-centered medical home that you'll see in the center of this slide. Over the past few years, URAC has identified and developed standards and programs that will help to promote cost-effective quality care. And you'll see that it's a continuum. I'm sure you all can speak even more closely to what you're seeing in the marketplace and how the trends of what we're seeing in terms of delivery of care are changing. The foundation for all of these new approaches to quality care really starts with that patient-centered medical home, providing the foundation. These programs, again, their focus is really to include the patient in providing coordinated care. You know, sometimes us in healthcare, we have to remember that we're actually treating a patient and that that patient needs to take responsibility and participate in their care. As part of the portfolio of provider services, as I mentioned, we've got building blocks here. So just to kind of take a step back and summarize what's happening in the industry. Historically, what we had was a fee-for-service process in the United States, where physicians and providers were reimbursed based on the services that they provided to a patient, to a consumer. And where we're headed in the evolution of the delivery system is one in which providers are now being recognized for their performance and how well they're actually caring for that patient and communicating across the continuum with their fellow providers to be able to look at the whole patient and be able to provide good quality outcomes for the care of that patient while still controlling costs. So if you look at this continuum, the patient-centered medical home is really about including those primary care practitioners, making sure that those primary care practitioners are really the ones that the patient goes to for their care. And then we're coordinating the efforts of that primary care practitioner with the specialty providers and making sure that if a patient goes to, say, an orthopedic group, that information gets communicated back to that primary care practitioner so that that primary care doctor knows what's happening with that patient and can, again, provide the best quality of care and efficient care. So what we have here are the accreditation building blocks, with the primary care medical home, patient-centered medical home being the foundation, leading to more sophisticated clinical integration where we have sophisticated communication happening across those stakeholders, to eventually accountable care organizations where an entity may be at risk or may be taking financial risk for the care of that patient. That is something that you've seen probably in the demonstration projects relative to Medicare shared savings programs. But I wanted to just, as I said, provide a brief overview of what's happening in the industry and the evolution of the delivery system. Now, the quality drivers really, back in the early 90s, there was identification of the quality aims that are critical to patient care. And they include safety, effectiveness of care, patient-centeredness, timely delivery of care, efficient delivery of care, and equitable delivery of care. And so, as I mentioned, when we looked at the 30 different accreditation programs that URAC currently has in its portfolio, you'll find that embedded in all of our programs are these quality aims. And we look at, for example, in our patient-centered medical home, When we consider the quality aim of safety, you'll find as we go through the standards that incorporated in the standards, in order to demonstrate safety, we're looking at things such as, does the practice have a registry? Does the practice look at medication reconciliation? Does the practice have a process to consider the transitions of care? For example, in terms of the quality aim of effective care, again, patient-centered medical home. Are evidence-based guidelines followed? Is there a focus to wellness? Is there a quality management program in place? I'm not going to read through each of these. Each of you will have the opportunity to receive a copy of the PowerPoint presentation and can have this information for your future edification. And as I mentioned, if anybody has any specific questions, we certainly can address them at the end of the presentation, or I can do that individually if you would like. I'd like to move on to our process. As I mentioned early on, our organization is committed to educational approach. And we do this through collaborative, educational, and a positive experience for our applicants. We have a staff model, which means that all of the reviewers that are involved in our accreditation process are actually employed by URAC. We use physicians, we use pharmacists, we use nurses, as well as attorneys and security experts for our specific accreditation programs such as HIPAA privacy and security. We have a proprietary internet application platform which really assists our applicants in uploading information, any information that may be a requirement for the accreditation or the recognition process. And we follow a rigorous process of review of an organization's policies and procedures, as well as specifically for our patient-centered medical home, we are doing an on-site assessment, which we'll talk a little bit more about. But I just wanted to reiterate the importance of our approach, which is meant to be a positive, educational, and collaborative interaction with our applicants. So let's get down a little bit more to the detail of the patient-centered medical home. You likely have heard of us, again, as it relates to the patient-centered medical home, because we first began development of our program back in March of 2010. And we'll talk a little bit about the development process here in terms of how our standards are put together and actually rolled out to the marketplace. We gather together those thought leaders that really are committed and passionate to a particular area. And when we developed our patient-centered medical home, we brought together a group of over 60 thought leaders to help us in the development of our program. We were not the first in the industry to develop a program, but we developed our program as a result of providers coming to us and saying that they wanted an alternative to what was available. Back in 2010, patient-centered medical home was really in its early stages, and if you'll recall, that was also the era of the Affordable Care Act and whether or not the Affordable Care Act was actually going to get implemented. So there are a lot of uncertainties in the industry at the time. There was a lot of uncertainty on the behalf of the providers of what the requirements were going to be and essentially how to transform their practices into patient-centered medical homes. So we rolled out our product initially in 2011, and over the past couple of years we have been getting feedback from the provider groups and from regulators and from various stakeholders, and actually ended up doing a revision to our standards and our process just recently this year. And that's what I would like to go through with you at this time. So first, let's look at the definition of patient-centered medical home. Really what we're looking at is a quality-driven, interdisciplinary, clinician-led team whose focus is to deliver and coordinate care, always putting the patient, the family members, and the personal caregivers at the center of all decisions. You'll notice that we particularly defined our program as interdisciplinary clinician-led. By that, we mean that if we have a group of nurse practitioners that would like to go through the recognition process for patient-centered medical home, they have the ability to do so. This program is not just limited to MDs. And essentially, our medical home product provides a comprehensive and individualized access to physical health. We're looking at physical health. We're looking at behavioral health. We want to look at the supportive and community services that are available to consumers and patients. And again, ensuring that patients are receiving the right care in the right setting at the right time. When we developed our program, really the principles and the foundations of our program took into consideration the patient-centered team culture, again focusing on appropriate access to care, making sure that there was individualized care planning, eliminating any healthcare disparities that may be surfacing. Again, does the organization promote care have a continuous quality improvement program in place? Are the resources that are being used cost-effective? Is there an infrastructure and operations in place? And is there a commitment to transparency? Those are the principles and the foundations of our program, and you'll see again that they will be embedded throughout the standards. So what is a patient-centered medical home? Again, we talked about standardization of care. Our standards really help practices transition from that concept of that fee-for-service to more of that performance-based outcomes for patients. And by using our standards, an applicant can implement processes and efficiencies that will allow for the better tracking of workflows and allow for the better communication, again putting that patient at the center of the care, which will ultimately improve patient care, ultimately improve outcomes, and ultimately improve compliance and give that consumer access to those services that are available in the community. Ultimately, what we're seeing on the commercial side is that some payers are actually providing increased reimbursements to those providers that are providing good outcomes to their patients. So you'll see in that left-hand corner, increased reimbursements from both state and commercial payers is also an outcome, a positive outcome for provider groups that go through the patient-centered medical home recognition. So our standards, which we'll be getting into very shortly, really focus on the whole person. And so as a result of the whole person, it's not just focused on disease or illness. There are components that are addressing wellness. Again, that formation of the patient-provider agreement. You know, patients need to understand in today's environment that they have a responsibility to participate in their care. On the commercial side, again, if a practice is going through the patient-centered medical home and they want their patient to participate, the patient has to agree to participate in the medical home concept. If they're not going to do so, then the provider will likely say, we'll not include you in our medical home processes. But again, it's going back to education of that patient and making sure that they also understand the benefits that are available to them by being part of a patient medical home. Care coordination is enhanced. We're making sure that we're accommodating health literacy and we have respect for cultural differences and needs. These are all critical elements of the patient-centered medical home and the standards. So just very briefly, I'm going to touch on how a practice or how a health center would go through the process of achieving patient-centered medical home achievement. There are 7 elements that are included, 7 modules, if you will, that are included as a requirement. They include the core quality care management. They include a focus to patient-centered operations. We look at things such as access and communications, testing and referrals, care management and coordination. We look at the use of an electronic health record if one is in place, and we look at the quality reporting and improvement processes that are available. Now, URAC provides, as part of our commitment to education, some information about the process, and over the next few weeks you'll start to see that there'll be more tools available to you that will be provided to help with the process, in addition to our standards document and our accreditation guide document. But essentially there are mandatory standards. There are 7 of them that must be met. And there are 28 essential standards that are part of the essential process. Practices must achieve a total of, this should actually read 55% or better. What we have done is actually created different achievement levels. You'll see on the right that we currently are offering a basic achievement. That would be that 55% threshold. And then we have the achievement with electronic record, which will have a greater percentage of achievement. And then we expect that we will also be rolling out a 3rd level of achievement for those organizations that have really surpassed the achievement with electronic record and have put in place more sophisticated processes for the patient-centered medical home. So please stay tuned. You know, those those achievement levels are soon to be released. But again, just as a very quick review, the 3 achievement levels would be the basic achievement, then there will be an intermediate achievement, and then there will be a patient-centered medical home practice certification for those that are further along in the process. So essentially the achievement is one in which the practice would provide us a self-assessment. We provide you with the standards, and you review the standards and do your initial gap analysis to see where your organization is in terms of being compliant. And if you are ready to move forward, you actually purchase the application, which is a very simple process that you reach out to us and we would provide you with a copy of the application to start the process. We have reduced the burden to the practices as a result of this new revision, in that we know that health centers such as yourselves and provider groups are very, very busy and don't really have the time to be completing a lot of paperwork or doing a lot of upload of information into an electronic portal. So as a result, what we will be doing is that, no, we are not going to be requiring any documents to be uploaded into AccrediTnet, but we will do a complete review of your documentation as part of the on-site review. So you'll see that that's that 3rd bubble across the arrow where we do the on-site review. Once the on-site review has been completed, the application or the results of the review will be scored. A summary copy will be issued to the practice, and then you would receive one of those achievements as I've just described in the previous slide. So let's get into a little bit more deeply the 7 modules. As I mentioned, the first module is the core quality care management module. We're also going to be looking at patient-centered operations, access and communication, testing and referrals, care management and coordination, electronic capabilities, and quality. So under the first module, which is the core quality care management, in terms of medical home organizational quality, these are the areas that we're going to be looking at. What kind of staff training is in place? What does your practice workflow look like? How are you addressing patient empowerment and engagement? Is the facility sensitive to health literacy, meaning is educational materials in Spanish, for example, available to a Spanish-speaking patient? Does the patient understand their rights and responsibilities? Do they understand that their participation in a medical home is one of being voluntary? So those are the standards that are included as part of the core quality care management. The second section looks at your operation. And included in the operation is really simply, do you have a registry? Do you know who your patients are? In other words, if you needed to reach a patient, say there was a medication recall and you needed to reach all of your diabetic patients that were taking that medication, do you have the capability to know who is a patient in your facility, and do you have the information to be able to reach out to them and connect with them to be able to provide them with information about a particular medication recall? The third section looks at things such as access to services. So patient access to services and information. Does the patient know how to reach you? Does the patient know how to reach their physician in the off hours? Is there an on-call system? Is there a after hours call center that or answering service that provides access for that patient to reach their primary care doctor? Under community services and resources, do you have access to comprehensive services and resources that you can refer a member of your practice to? For example, say for instance, your clinic does not provide gynecologic services. Do you have a relationship with, say for example, Planned Parenthood, and do you provide information to that patient about how they can access those community resources? Is there a method for tracking follow-up of the community resource referrals? So if you do refer a patient to Planned Parenthood, as I used as an example, is there a method for Planned Parenthood to then refer back or follow up back to the clinic to let them know that that patient has been seen? So again, those cross specialty communications, what kind of communication is in place? Managing tests and results. Again, is there a documented process for managing a test? So if a patient comes in for lab work, for example, is there a method for following up with that patient to make sure that they get their blood work results or their x-ray results or whatever tests that patient may have had prescribed for them? Referral process, again, we're looking at is there a method in place for sending patients to specialists? Is there a method for tracking this? We're looking at, when we're doing our review of these standards, what we're looking for is, do you have a process in place, a policy and procedure, if you will? And when we come out to do the on-site review, our review team will interview staff specific to these standards to ask you to demonstrate to us how indeed you have implemented your policies and procedures for these specific areas. So for example, moving on to Section 5 for care management and coordination. So we're looking at wellness and health promotion. Remember that I mentioned early on in the slide deck that our standards are not just focusing on disease. Our patient-centered medical home also wants to know that a provider group, a clinic, is focusing on promoting wellness and doing a health risk assessment with consumers and patients and providing them with information about how to promote their wellness. If they're well, how to stay well. If they're not well, how to get back to that area of having their disease under control. And that flows right very nicely into the individual care management. Again, informed decision-making with patients, letting them know that they are at the center of their care, particularly a diabetic, for example, understanding that they are going to be referred to, say, for example, a nutrition class, and the responsibilities in terms of going to that nutrition class and actually participating and learning about how to improve their diet. Again, in individual care management, medication review and reconciliation. Is that patient understanding what their medication prescription is? If they have been admitted to the hospital, when they are discharged from the hospital, do they understand their current medications? Has there been a good coordination of care transition from the hospital to back to home with a written plan that the patient understands. So these critical elements of care management and coordination that look at from wellness to possibly a disease diagnosis to a hospitalization and to coordination of the care. So you'll see that we're looking at the whole patient and the continuum of care. Now, critical to that, again, and this is just a slide number 23 is a continuation of the care management and coordination process, which looks at, again, that self-management and access to those tools that may be available for them to manage their chronic conditions. The key to all of this is that electronic health record. Now, we know that across the country, the uptake of electronic health records has been diverse. There are some areas of the country where there's been a large amount of uptake of electronic health records, but we also know that there are some areas of the country where there is still a need to move forward with the electronic health record process. So our achievement does allow for a patient-centered medical home to seek achievement without the electronic health record. So that's an important consideration. It allows the organization to put in place those other critical elements of a medical home while still considering what options are available and what budgetary considerations may have to be given to electronic capabilities. But if an organization does have an electronic medical record in place, you'll see that there are these standards and elements that are aligned with meaningful use for those organizations that have been participating in or been recipients of grants. These allow for making sure that they are in compliance with meaningful use and can demonstrate that not only has the electronic health record been implemented in a provider group, but it's also being used. It's one thing to have it installed. It's another thing to make sure that all the clinicians are indeed educated about the use of the electronic health record and are indeed using it. And then the last element is the quality performance reporting. Again, this is kind of what it's all about. For those of you, who are nurses, if it's not documented, it never happened. So performance reporting and tracking. This is an opportunity for the patient-centered medical home to really take a deep dive into those areas that they are collecting information and making sure that they are demonstrating as part of their process how they track and report information, how they validate that reporting, and who is actually doing the reporting. So we provide the organization with some guidance in terms of how to actually go through the whole quality, performance, and reporting improvement process. So I'd like to just take a moment and recap the process. So again, the critical differentiator for URAC's patient-centered medical home is that the review is done in person. So we are actually coming out on site, and the review is done by a clinician, so they're all registered nurses, coming to your organization to actually sit with your team to go through the documents that you have gathered to demonstrate to us that you are in compliance with the standards. So it's a document and a data review. It includes an audit of patient health records. It includes an interview with leadership, staff, patients, and it also includes observations. So what will happen is, again, the organization identifies that they're ready to move forward in the process. They start to assemble all of their documents over a period of 6 months. They notify us when that process has been completed. We send a reviewer out for, it's usually 1 day, 1 reviewer, or it could be 2 days, 1 reviewer, depending on the size of the provider practice. Once the on-site review has been completed, then a decision, the information is submitted to our accreditation committee, which consists of Again, subject matter experts that participate on our committees. The application is submitted in a blinded fashion so that no one on the committee knows the name of the provider group. And once the committee is assured that the group has indeed met all of the requirements, then the provider practice achieves the recognition. So why URAC? Just in summary, because I want to allow some opportunity here in case anybody has any questions. But the differentiator for us is that we are educational. Our staff, our reviewers are all employed by us. They are subject matter experts. That is one of the values of the on-site review, is that they can share positive feedback to the team, to your team immediately, and can also serve as a subject matter expert in terms of offering solutions and areas where improvement may be appropriate, and they may be able to offer some suggestions about what improvement and specifically how to get there. So it's real-time interaction with a reviewer as opposed to submitting a document electronically and just having communication done on an electronic basis without interaction with someone that really understands patient-centered medical home. Our standards are not prescriptive. You'll note as I was going through them, they're pretty general. We are not telling a practice how to do it. Your business is your business. Your demographic is your demographic. So we provide guidelines and we identify what is a critical element as part of a patient-centered medical home, but we allow the provider to really put into place the policies and procedures and practices that are important for your demographic group. And for every demographic group or for every organization, they're going to be maybe a little bit different. In some areas, yes, it's pretty standard. You know, for instance, the registry, you know, I mean, you have to have a list of your patients, and that's pretty standard about, you know, how you're going to be able to put together that list of your patients. But how you approach communication with your consumers, with your patients, how you manage their the communication, say specifically for access to care, that may be unique for your demographic. So we don't tell you how you do it, but we tell you what you need to make sure that you're looking at when you're putting together your workflows. The URAC accreditation process and recognition process really builds upon integration and care coordination capabilities. So if an entity is at some point going to be part of a clinically integrated network, then certainly having the foundation of the patient-centered medical home would be critical to that provider group. Again, if the long-term plan is for that provider to be part of an accountable care organization, then you want to make sure that there's a good foundation in place, because once you get to that accountable care organization design, and we're talking about risk and we're talking about outcomes being tied to reimbursement, then you want to make sure you have a good foundation in place. And that can be achieved by making sure that a practice has truly transformed to a medical home. We can assist with that through the on-site review component. And again, in terms of the meaningful use specific to the electronic health record, our standards do meet those requirements. And I have already touched on the progression to risk-based contracting and population health. So you can see where I hope that during our time together, I've been able to demonstrate to you that our patient-centered medical home is really the foundation for where we see healthcare going in the future. And with that, I would like to give you all an opportunity to ask me any questions that you might have. I will tell you that I really sincerely appreciate the opportunity to speak with you today. This slide has my contact information. I can be reached at that phone number at any time. You can also reach me electronically through email. And I would also refer you to our website, which is www.urac.org. There is a wealth of information on our website about not only patient-centered medical home, but about our whole provider suite of products. And I would encourage you to, in your free time, and I know that not a lot of us have a lot of free time, so if you are interested, please feel free to use us as a resource. And with that, I would like to open it up to any questions that anyone might have.
Thank you, Cindy, for this outstanding presentation. We're going to begin the question and answer session. If you have a question, please submit it through the question box on your control panel, or use the hand raise icon on your line will be unmuted. One more time, I want to thank Cindy for this excellent presentation. We have some questions for you, Cindy. The very first question says, do requirements change for health centers that serve particular populations? For example, requirements for public housing primary care grantees or homeless grantees?
No, that's an excellent question, and thank you for asking it. Our standards are not specific to any specific provider group. So, for example, in your situation versus say a provider group that is providing services, a commercial provider or private provider group that's providing OBGYN or orthopedic services, as long as you're providing services that are really primary care, then the standards are the same for everyone across the board. So there's nothing that would be specific for your entities. I hope that answered your question.
Thank you, Cindy. We have another question for you. On average, how long is the entire process from initial visit to final approval for accreditation?
Oh, okay, that's a great question. In terms of the process itself, we allow an organization 6 months after you have indicated to us that indeed you want to start the recognition process and you make your purchase, then you have 6 months to assemble your information for us. And once that is completed, then we would schedule the on-site review. And once the on-site review is completed, the review staff generally take probably between 30 and 45 days to assemble their final results. It's called an executive summary that is submitted to the Accreditation Review Committee. And our executive committees, our accreditation committees, meet on a monthly basis. So depending on where a applicant falls in terms of when the executive summary is completed and when the committee meets again would determine exactly what the turnaround time was. Now, that being said, if a provider has a urgent issue to get through the process quickly, we certainly have the capacity to do that. Just to give you an example, we have some companies that are seeking accreditation. For example, say a case management company that is in need of accreditation in order to meet the requirements of a contract. In those cases, we give the customer 6 months to complete the process, but if they complete it in 2 months, as soon as they are ready for us to take a look at their information, we will assign a reviewer. So the same would hold true for this process. As soon as the provider or the health center is ready for us to come out and do the visit, we will schedule a reviewer to come out and do the visit. And I hope, again, that answers your question.
Thank you, Cindy. We have one more question. Can you provide an example of some of the challenges your organization observes among safety net providers such as public housing primary cares?
I would say some of the challenges are the documentation process. You know, we all are very good at caring for our patients, but have we documented it? And so that's likely where the biggest challenge would be, is to do that gap analysis to see, you know, what do you need to put in place. We have a look-back period from the time that you've actually started the process. So, for example, say you are very interested and you think you've got a really, you've looked at the standards and you say, you know what, we're ready to move forward, we could do this. You let us know, you start the process, you then gather all of your information, and you schedule your appointment to have your on-site review. Our look-back period when we do that on-site review is from the time that you've told us that you're ready for us to come out and do the visit. We know that looking back at what your operation was 6 months ago, a year ago, is not meaningful. You have started the process when you have actually called us to let us know that you want us to do the review. So my recommendation would be, if it's something that's important to your health center, to seek recognition, and it's a differentiator for you, or you merely would like to go through the process to ensure that you are really poised to meet the requirements, then I would say take the plunge. And again, we are educational. We will assist you in your endeavors to get through the process. I would like to, I know we're coming up on the hour, so I would like to also just make note that we also provide regular patient-centered medical home workshops. And these workshops are conducted by our reviewers, and the reviewers go through each standard and provide examples of exactly what it is that we're looking for. So for anyone on the line that is interested in, again, moving forward in the process sooner rather than later, I would encourage you to look at our education workshop schedule on our website and consider attending one of those patient-centered medical home education workshops. I think you would find them invaluable for assisting you in your readiness analysis and also getting started with the process. As I said, our reviewers provide really a wealth of information. Additionally, if the group, after this presentation today, which was really just very high level, if the group as a whole, Dr. Leon, would like to have a more in-depth presentation by one of our reviewers going into detail on each of the standards, we would be happy to do so to this group. Just let me know and I can make the arrangements to do so. So we could sort of do a dedicated workshop for the federally qualified healthcare centers.
All right, excellent. Thank you, Cindy. We have a couple of questions for you. Do you have to start over if you don't complete your profile in 6 months?
You can ask for an extension. You can,
okay.
Yes. What you need to do is just provide us with a notification that it's going to take you some extra time, and that is available. We do have extra time written into our contracts.
Thank you. And we have another question. How disruptive is the site visit to the daily routine of a health center?
Oh, we are very sensitive to the fact that you still need to conduct your daily business. So we will do our very best to make it as littlely, I'm probably not using the correct language, minimally disruptive as possible. We send an agenda prior to the on-site visit, and at the on-site visit, prior to, you're going to see the agenda. You will have identified who are going to be the appropriate people. For example, on the patient interview side, obviously you're going to need to get permission from the patient for them to be interviewed by us. So you'll have established that. We just really need a quiet room, conference room, break room, and the more readily that you can provide us with the information, the more smoothly it goes. So if you're well organized and you have your binder ready to go, it just makes the process more efficient for both the review team as well as for your team. But again, we give you an agenda so you know exactly what it is that we're looking for. And the other critical piece is what we're doing there is just looking at your organization as it relates to the scope of the accreditation. So we aren't looking at anything else that's unrelated to how it would apply to patient-centered medical home achievement.
Thank you. We have, I think that we have time for one more question. Does URAC look at patient satisfaction surveys?
That's an excellent question. See, you got to zing me on the very last question. I'm going to have to get back to you because I honestly don't know that we do. I'm not a reviewer, so I will take that information back to our review staff and ask them. So the question is whether or not URAC uses the patient satisfaction
survey.
I would say, yeah, the survey. I'm going to take a stab at this and say that what we're looking at is that you've got a mechanism in place to do a survey, but are we actually looking at results of that survey and incorporating the results as part of your score? I'm going to say no, but I'm going to get clarification, and I'll get back to Dr. Leon about that, and you'll be able to provide specific response to that question. But thank you. That's a great question.
Thank you.
I go back to every day I learn something new. So thank you.
Thank you, Cindy. Thank you one more time for this outstanding presentation. We need experts like you to keep us abreast on topics like the one that you just presented. We would like to share some resources with the people attending the webinar. The very first two are for the Agency for Healthcare Research and Quality. And the third one is from the Blue Cross Blue Shield Association. And the last one, the Health Policy Brief, is from the Robert Wood Johnson Foundation. All of these resources and the link of today's webinar will be emailed to you after this webinar. To all of our attendees, please complete the post survey. This helps the National Center for Health and Public Housing to improve our webinars. If you have any training or technical needs, please contact any of our staff members. Once again, thank you very much for attending this webinar, and thank you to Cindy. Thank you very much, and have a good afternoon.
And thank you very much, everyone, for the opportunity. And please feel free to contact me if you require any additional assistance. Thank you again. Hope everybody has a great afternoon.